of this session from Tehran University of Medical Science. In this webinar, we will cover panels of neurology, hematology, and ill child in 2 halls. In this hall, we will hold the neurology session. We have invited physicians from all over the world to share their precious experience with us. In this hall, we are going to have neurology panel with the subjects of the status epilepticus, epilepsy, autoimmune encephalitis, and movement disorders. And just a few reminders before we get started. This webinar is broadcasting live on our YouTube. Due to the number of participants, make sure that you have muted your microphone during the lectures. If you have questions, we encourage you to ask them by chat section. And there's a webinar tool called Raise Hand, so we will be able to hear from you if you have time. If you want to receive a certificate of attendance in this Congress, make sure to register on our website and reserve a seat on your desired panels. For our Iranian audience, if you want to receive CME, don't forget to participate in the panel quiz in maximum in 2 days in cmequiz.ir. Don't forget to follow our social media pages and YouTube channel to stay updated on our next events. And with that, we will open today's webinar. I would like to introduce today's panelists. First of them, Professor Mahmoud Mohammadi, full professor of neurology in Tehran University of Medical Science, with the subject of how useful are homemade videos in diagnosis of epilepsy-like disorders in children. The second one is by Professor Gabriella Rosa from Department of Human Pathology and Adult and Developmental Age Units of Child Neurology and Psychiatry, University of Messina and Italy, with the subject of updated approach to status epilepticus. The third lecturer is Professor Homayoun from Department of Neuroscience, University of Pittsburgh, from Pennsylvania, United States of America, with the subject of updates on pediatric movement disorders. The fourth one is by Professor Suvasini Sharma, from Neurology Division, Department of Pediatrics, Lady Hardinge Medical College, and Kalavati Saran Children's Hospital, New Delhi, India, with the subject of pediatric autoimmune encephalitis. And the last one is by Professor Sreeni Tekki-Rao from Department of Pediatrics, Luton and Dunstable University Hospitals, from United Kingdom, with the subject of status epilepticus. We are very lucky to be with you today. And our first lecture is by Professor Mahmoud Mohammadi with the subject of how useful are homemade videos in diagnosis of epilepsy-like disorders in children. Thank you.
Hello and greetings from Tehran. First of all, I would like to express my deepest gratitude to the organizers of this virtual webinars, especially Dr. Aghai and Dr. Ashrafi. And my talk today, I'm going to talk about the very simple but available means to monitor paroxysmal events at home. And the title of my talk is How Useful Are the Homemade Video Clips to Differentiate Paroxysmal Events in Children? And I'm going to talk about my experience, my local experience about the usefulness of this very simple and practical means in evaluation and diagnosis of the paroxysmal events in children. And the outlines of my talk today are how to take a video from a paroxysmal event and to share some common scenarios from our center and our outpatient department, and to discuss about these scenarios and the useful hints in each history and also the video provided by the parents. And at last, I would like to have a conclusion and to point out some key points about this issue, and also talk about the usefulness. And also, I will introduce an algorithmic approach to have homemade video clips in children with paroxysmal events. And how to have the best clips. It's very important because you should teach to the parents that how can they provide a useful clip from the paroxysmal events of their children. It's very important to have a standby smartphones always ready to hunt the events, and also watch for warning signs such as prodromal signs before the seizures or any paroxysmal event. Also, aura is very important because it's type of seizure and it's a sensory type of seizure. And also manage the time, and it's very important to manage the time and to be calm to have a useful video for diagnosis and also management of these events. It's very important but simple matter that taking the video in a horizontal position, not a vertical one, because you have a wider field to evaluate the paroxysmal events. And it's very important also to have the whole body in the video clip to evaluate the movements of the limbs as well as any movement in the face. And also it's very important to have the microphones and turn the microphones on, because the voices in the clip is maybe as important as the video clip by itself. And if we have a high resolution video clip, it's very useful to have a very blurred and unclear low resolution ones. And to teach the parents to trim the video in important seconds and in important minutes of the event, not a very long video to tire and exhaust the physician to evaluate these events. Let's have some clinical scenario and discuss about them. Okay, a gentleman comes to your clinic and complains anxiously about her daughter's night sleep events. His daughter is a cute 7 years old, who got some nightly strange movements of awakening fearfully at or near dawn, with eye widening, moaning, and stretching her arms, not responding to her parents appropriately, and after about 1 minute or two goes to sleep again without remembering the event at morning. Events commenced 2 years earlier, and parents sought medical consultation everywhere and were referred to your clinic by one of the colleagues. Some medication administered such as melatonin, pyridazine, benzodiazepines, insufficient dosage and period with little, if any, benefit. On neurological and developmental evaluation, she is completely normal. That shows the following homemade video clip and tells you that these events are irregularly occurring every night or two. Okay, what is the useful historical hints in this short story? The events occur at or near dawn, and this is not in the favor of a sleep disorder, as you know. And these events are pretty frequent, occurring every night or two, with multiple recurrences. And the events also were unresponsive to prescriptions usually administered for sleep disorders. Let's have a look at these events in a homemade video clip. Okay, what are the useful video hints in this short clip? The events is pretty stereotypic. Slight eye deviation to the left and coming back midline again, and loss of awareness and non-responsiveness are imminent in this video clip. An extension of the right arm with flexion of the left, which is the typical figure of 4, which is a hallmark of seizures, especially tonic phase. Later, we have pointed out in the long-term video EEG monitoring that the child is suffering from a type of epilepsy, frontal lobe epilepsy semiology, which are quite evident from this short video clip provided by the parents, and was further confirmed by further studies such as long-term video EEG monitoring in our center, at our center. Let's have another clinical scenario. 10 days old normal term infant with uneventful C-section delivery recently developed suspicious jerks at sleep, which are clearly depicted in the following homemade video clip taken by his parents. His dad has also some jerky movements at night sleep, while he is absolutely normal. He has normal breastfeeding without any accompanying sign or symptom. The infant has no abnormal movement or behavior at wakefulness. Let's have a look at the historical useful hints. These jerky movements, first of all, these jerky movements occurs only at the sleep. The infant has normal general movements at wakefulness, and there is no abnormal delivery or previous history. And also there are no such jerky movements when he is awake. Dad had also similar movement at the sleep, and he has also the similar movements, jerky movements at the sleep. Let's have a look at the video clip provided by the parents. You can clearly see in this clip that the infant has some jerky movement with the foot and also hand. This is quite fragmentary and brief. Okay, let's have an analysis from the useful video hints. The jerks are fragmentary as you saw in the clip, and the jerks are very brief. The movements are very brief. The jerks are not focal and lateralized, but is fragmentary and on both sides. And you cannot find any stereotypy in these movements. Infant does not awaken by such movements, and according to the parents, there are no similar movements when he is awake. Okay, on further diagnostic evaluation, we reach the diagnosis of benign sleep myoclonus because the EEG was quite normal, and also the developmental neurologic exam were also normal. So the final diagnosis after workups was benign sleep myoclonus. Let's have another scenario, clinical scenario uh, in this issue. A 4-year-old girl with strange movements since she was 2. These movements consist of rocking when she is prone, with striking thighs against each other, with marked preoccupation but no loss of awareness. This behavior occurs only when she is awake. She is somehow delayed and acquired all developmental milestones a little late. Walked at the age of 2 years and recently began to talk. She has no history of eminent seizure, and these movements were reluctant to any anti-epileptic medications. Useful historical hints in this story is movements occur exclusively at wakefulness. She is not unconscious although preoccupied. Mom could stop these movements by stimulation. Semiology are the same as rocking when prone and striking thighs together. Movements usually do not occur when she is playing, and she has global developmental delay on developmental and neurological examination. Refractoriness to all anti-epileptic medication. Let's look at this video clip provided by the parents. You can see clearly the rocking movements, also striking eyes and legs together. She's awake, she's conscious, but very occupied, and this could be stop these movements by calling the child or stimulating physically by the parents. The useful hints, video hints, if child is awake and responsive, although she is preoccupied. The stereotypic movements are typical, as rocking movements and also the movements of the thighs. Movements could be stopped by calling for another stimulus. Events are in prone position with rubbing genitalia. Crossing posture of the legs is prominent, and on further diagnostic evaluation, it has been revealed that the child is have gratification behavior. The EEG was quite normal. Video EEG monitoring and long-term EEG monitoring in the events were quite normal, and there was no electrographic counterpart of these movements, except the movements in extra lanes of superficial electromyography. Okay, uh, let's see how useful are the homemade video clips. It is quite effective, it is quite efficacious, and it's also quite efficient. And if you want to further clarify what's the meaning of effectiveness, it is that you can use this strategy for every children that uh, who has some type of paroxysmal events in ideal conditions. And it is efficacious because you can practically use it in your children who suffers from some paroxysmal event at wakefulness or sleep in real condition. And it's quite efficient because it is very available, it is very practical, and it's also very economical in comparison to sophisticated diagnostic studies. And the key points in these stories is that epilepsy-like disorders are very similar to epilepsy and both consist of abnormal movements or
تفضل.
behaviors. Homemade video clips are clinical means helping us to reach the correct diagnosis of
أبصر
this
شتوي
event,
مقبلة
whether
دومين
it's
لما
a
دومين
seizure or
بين عليك من
seizure-like
شكلك
disorder.
شنو
Teaching
هذول
family and
الصغار بين عليك بسرعة
video record their disorder, and always you should watch the clips together with parents or caregivers.
برأسك برأسك اللي يسوي
And I
لقاتي
also
عاد جوزين لو من
provide
جوزين
a correct approach to these paroxysmal events
صدق كذي
by providing
يقول لك احنا
the
الشتاء
unmet
بدايته
if you can
بطلت
provide
الحين هذا
clinical
سير
information by taking the root history, also by simulation. It's very important when you have a paroxysmal event. Firstly, ask the patient, the parents or caretakers to simulate the events or the movements. And if they could not do that, you should, by your own, do simulation for them and asking them, is it similar to your child's movements or paroxysmal events? And at last, but not at least, to have video clips, and you should watch together with parents and or patient or the caretakers. So clinical data could be informative, and if it is informative, we should try further plans in diagnosis and also treatment and also patient education domains. And if it is not informative, we should further work on patient with some more sophisticated or more extensive studies such as polysomnography or long-term video EEG monitoring to further study these paroxysmal events and to clarify and to diagnose whether these movements are epileptic or they are non-epileptic in nature. At last, I would like to conclude that having homemade video clips are very practical, useful, as I said, effective, efficient, and efficacious means to study paroxysmal events in children, especially in countries that there are not some sophisticated facilities to study paroxysmal events. And it's also very useful for general pediatricians and also pediatric neurologists to study the movements or the paroxysmal events in children in outpatient setting. And it's also very useful to plan further evaluation, more sophisticated, such as polysomnography or long-term video EEG monitoring. Thank you so much for your attention.
We would like to thank Professor Mohammadi for his valuable lecture. Now we are honored to have the lecture of Professor Gabriella Rosa with the subject of updated approach on status epilepticus. But just before we go to the next session, there are a few reminders we want to mention. This webinar is broadcasting live on our YouTube channel. Due to number of participants, please make sure that your microphone is mute. And if you have any question, please use the chat section. If you want to receive a certificate of the attendance in this Congress, make sure to register on our website and reserve a seat on your desired panels. For our Iranian audience, if you want to receive CME credit, don't forget to participate in the panel quiz at a maximum of 2 days in cmequiz.ir. Don't forget to follow us on the social media and YouTube channel to stay updated on our next events. It would be appreciated if Professor Gabriella Rosa start her lecture. Thank you.
Good afternoon to everybody. My name is Gabriella Di Rosa. I'm the chair of a unit of child neurology and psychiatry of the University Hospital of Messina in Italy. And I'm going to talk about an update on status epilepticus. Lots of years ago, in cuneiform tablets has been reported a description of a very severe condition that was considered as a demonic possession, and it was considered the first reports. They were the first reports of SE in the history. In 1989 and 1993, International League Against Epilepsy reunited a task force with the effort to define classification and definition of SE, and they considered a chronological criterion to define continuous epileptic activity. And so SE has been defined as a condition in which a unique seizure or more than one seizure lasts over 30 minutes or 20 minutes without recovering of function and consciousness. SE has been recently, the time interval to consider SE diagnosis has been shortened at 5 to 10 minutes in the last update of ELAIC classification published in 2010 and revised after a colloquium on status epilepticus held in London and Pittsburgh on 2015. If we talk about pediatric age, we have special structural and functional aspects that need to be attentioned. And one of them is GABAERGIC receptor structure in the immature neuron that has been shown to produce an outflow of chlorine ions from the inside of the neuron instead of an inflow. This leads to hyperexcitation of the neuron with suboptimal efficacy of anti-epileptic drugs and paradoxical effect with benzodiazepines treatment. On the other hand, glutamate receptors in the immature brain shows specific configuration and different representation, leading to increase of intraneuronal calcium entry and hyperexcitability. Taken together, all these molecular aspects, SE has been considered as a dynamic state in which the changes observed during continuous epileptic activity include a rapid internalizing of GABA receptors and a moving from subsynaptic sites to synaptic membrane of AMPA and NMDA glutamate receptors. This leads to an increased benzodiazepines resistance and persistence of epileptic activity. Neurophysiopathological change has been for a long time reported in patients in brain of the animal models and patients with SE, Meldrum and colleagues in 70s reported glutamate-mediated changes in neurons mediated by excitotoxicity and mitochondrial dysfunction, oxidative stress release that contribute to neurons and structural and histological changes, neurogenesis and geogenesis. And in addition, immunoinflammatory processes are highly involved in SE pathogenesis and sustaining the neurophysiopathological chains during continuous epileptic activities. And the most involved cytokines include interleukin-1 beta, TNF-alpha, and interleukin-6. Also, glia and blood-brain barrier appear to be strictly involved since a different permeability of the blood-brain barrier has been shown. Etiology is one of the most important prognostic factors, and it's very important for physicians that start to approach to patients with SE. We can have a lot of scenarios in which the child can be a previous healthy child with a prolonged febrile convulsion or with acute CNS insult, or seizures are the first manifestations of idiopathic epilepsy, or seizure are a further manifestation of a previous diagnosis of idiopathic epilepsy. Then we have children with a history of previous neurological disease in which the SE occurs as a consequence of a new acute insult of the CNS or as a consequence of a febrile illness. Children with no evidence of acute neurological insult, but with pathogenic knocks of various kinds affecting the CNS can present SE. And we also have a group of children in which we fail to identify a known cause. Chin and colleagues in 2006 reported on 226 subjects with SE aged between 1 month and 15 years, with a prevalence of 17 to 23 episodes per 100,000 children per year, in which the majority were located in the first year of life because of the structural and functional aspects that we discussed before, and fever was the most frequent cause under 1 year of age. About prognosis of SE in children mainly depends on the etiology, with the worst prognosis associated with anoxia, infections of the central nervous system, and severe head trauma, and the best prognosis associated with prolonged febrile seizures, SE in subjects with idiopathic epilepsy. So let's go to see the results of the great effort of ELA task force from 2015 with the attempt to classify according to a different point of view SE. They talk about operational criteria to classify patients with SE and identified chronologically 2 time points, T1 and T2. 2 main aspects can define SE. The one is that SE is now defined as a condition resulting either from the failure of the mechanism responsible for seizure termination or from the initiation of the mechanism which lead to abnormally prolonged seizures. And SE is a condition in which we can observe long-term consequences, including neuronal deaths, neuronal injury, and the alteration of neuronal networks, depending on type and duration of seizures. Trinka and colleagues defined 2 dimensions of intervention or operational time points for patients with SE, in which the first one, time point 1, is one that established the length of the crisis, the minimum interval of time to have continuous critical activity to be considered as SE, and the second time point 2, is the one which expresses the minimum time necessary and sufficient for critical activity to trigger neuronal damage with long-term consequences. The data, the literature data supported that T1 can be set at 5-10 minutes and T2 at 30 minutes, but this assumption has been validated only for tonic-clonic convulsive SE and not for non-convulsive SE. And then 4 diagnostic axis of SE has been proposed by Trinka and colleagues, in which semiology, etiology, EEG, pattern, and age of the patient represent the main keys of diagnosis. Semiology is very important because status epilepticus can be convulsive, the one that we have studied more abundantly previously in the literature, and can be non-convulsive, focal, or generalized. The latter is more difficult to be diagnosed and identified unless you have the possibility to record an EEG, especially in emergency department. The etiology, axis 2, can be divided in 2 main categories: known etiology, in which you can promptly identify the cause, and unknown etiology. This is very crucial, as this is a very challenging point to address treatment. And axis 2, EEG-related pattern, is a very elegant and very important aspect of SE diagnosis. However, unfortunately, there is no specific EEG pattern associated with a particular type of SE. So we can rely on EEG pattern because just for early identification of some specific idiopathic epilepsy, for example, occipital epilepsy, such as early onset Panayotopoulos syndrome, or some specific patterns characterized by periodic discharge or rhythmic delta and spike wake activity. But we do not have a specificity of EEG to diagnose a specific peculiar type of SE. And localization can be studied according to axis 3 by EEG assessment. This is, for example, EEG ictal EEG recording in a 5-year-old patients with autoimmune encephalitis that have a focal motor seizure with a focal onset on the left anterior regions and suddenly generalizing and then terminating with delta monomorphic activity on the same regions. This is a 9-year-old male patient with occipital epilepsy that had prolonged focal seizures without consciousness impairment, and this was an ictal EEG recorded during one of these attacks. The age of the patient is a very important aspect within the approach of the clinicians to patients with SE, because it can be very different, the diagnostic approach, the laboratory exams, the different etiologies that can be considered in neonatal age, infants, children, and adolescents. And a very different talk need to be taken about neonatal period, in which all criteria proposed by Trinka and colleagues are difficult to be applied because they characteristics of SE neonatal period are very different from the other ages. According to chronological criterion, SE can be distinguished about according to the duration in initial 5-10 minutes, defined from 10 minutes to 30 minutes, refractory from 30 minutes to 60 minutes, and super-refractory or malignant beyond 24 hours of continuous epileptic activity. In 2016, American Epilepsy Society proposed these guidelines in which an algorithm with 4 phases has been shown, including stabilization phase, circulation, airway, breathing, intravenous access, lab tests as a first step, and then treatment starting as the first line, second line, and third line. This is a very recent review on pharmacotherapy for pediatric convulsive status epilepticus that confirm the need to distinguish SE in different stage according to the duration of continuous epileptic activity, because the treatment choice is strictly related to duration of seizures. Initial status epilepticus stage 1, 5 to 10 minutes, can be managed out of hospital when intravenous access is not available. We have 2 milestones of treatment at this stage involving oromucosal midazolam and endorectal diazepam. We can use intramuscular or intranasal midazolam. However, the use of midazolam by this 2 route of administration is not registered for this use in many countries, such as in Italy. As a general rule, it is advisable to avoid the overall administration of more than 2 doses of benzodiazepines, because the literature showed that it doesn't increase the response, the clinical response, but it increases the risk of respiratory distress. And when the patient is admitted to emergency department and the intravenous access is available, we can use, we still use benzodiazepines. So we have lorazepam, diazepam, and clonazepam. Now we are at 10-30 minutes of continuous epileptic activities. This is stage 2, in which we have to choose different molecules. We have phenytoin, valproate, levetiracetam, lacosamide. If the patient failed treatment of stage 2, we have to pass to stage 3. The patient needs to be admitted to pediatric intensive care units and treated by specialized personnel. So we can use anesthetics as drugs to induce sedation, profound sedation in these patients. One of the aim of the goal of the treatment is to maintain suppression burst EEG pattern with propofol, thiopental, pentobarbital, midazolam as in continuous infusion. When the patients go beyond 24 hours of continuous epileptic activity, they have super-refractory status epilepticus. It's a very malignant condition, very severe. No randomized controlled trial actually exists for the treatment of this condition. Some proposed treatment strategies include ketamine, magnesium sulfate, pyridoxine in small children, topiramate, and immunomodulation. This is a very recent review in which autoimmune assessments in serum and CSF need to be performed also to address the treatment. And these are two known immune-inflammatory conditions associated with continuous epileptic activity, nausea and virus associated with suspect infection or toxic or structural or metabolic, but no identified cause, and virus with fever starting between 2 weeks and 24 hours prior to onset of refractory seizures. These two have been reported to benefit from immune therapies, including the steroids or monoclonal antibodies, immunoglobulins, and plasmapheresis. If we know the patient we have in front, and we know that is affected from a specific epileptic syndrome, such as Dravet syndrome, we can try to treat this patient with specific targeted therapies, such as tiripantol in Dravet syndrome, levetiracetam, lacosamide, or carbamazepine in newborn with KCNQ2 related epilepsy, or pyridoxine in the very small children or newborns with unexplained prolonged seizures. And we have to keep in mind that some drugs need to be warranted if we suspect a inherited metabolic disorder such as valproate. So in conclusion, SE is a dynamic state with progressive benzodiazepine pharmacoresistance, and early treatment with benzodiazepine and rapid escalation to second-line non-benzodiazepines is recommended. We still do not have treatment strategies for refractory status epilepticus. Probably early polytherapy based on synergies between anti-epileptic drugs may be a potential therapeutic strategy for future studies. So thank you very much to all my group, and thank you very much for your attention.
We would like to appreciate Professor Rosa for her spectacular presentation. And now we are honored to have the presentation of Professor Houman and Homayoun with the subject of update on pediatric movement disorders. But a few hints just before we go to the next session. This webinar is broadcasting live on our YouTube channel. And please make sure that you have muted your microphone. And if you have any questions, please use the chat section. And if you want to receive the certificate of attendance in this Congress, please register on our website, which is available in the chat section, and reserve a seat on your desired panel. Now we are going to have the presentation of Professor Homayoun. Thank you.
Hello, I'm Homayoun. I'm a movement disorder neurologist at the University of Pittsburgh, and I'm happy today to be with you to discuss an update in pediatric movement disorders. I'd like to thank the organizers of the conference for the opportunity to present here. As you know, the range of movement disorders in pediatric population is broad, and these are often classified based on excess or lack of movement to hyper or hyperkinetic movement disorders. Hyperkinetic disorders consist of 5 main category based on the phenomenology. These are tremor, dystonia, chorea embolismus, tic and stereotypy, and myoclonus. And there are also other distinct categories such as paroxysmal dyskinesia, drug-induced dyskinesia, and functional movement disorders. The hypokinetic movements, which are less common in pediatric population, include Parkinsonism and spasticity. The pie chart here shows a breakdown of a case series that was presented to Pediatric Movement Disorder Clinic and showed that majority of those patients present with tics or Tourette syndrome, and other subsets present with psychogenic disorders. But among the organic disorders, dystonia was the most common, with 12% share of the total population, and the other movement disorders are each a smaller share. I'm going to use a case-based approach to highlight how we approach these cases where there is movement disorders present, and include some pearls about some recent findings. The approach to pediatric movement disorders is based on three principles: phenomenology, temporal pattern, and associated features. Phenomenology is based on the type of movement disorder that is present and guides the differential diagnosis and management. Temporal pattern focuses on the onset and course of the symptoms. The onset of the symptoms would be acute or subacute, and in those cases, there is a broader range of differential diagnosis that would include entities such as vascular disease, infections, inflammatory disease, or autoimmune disease, along with the other causes. And if it's a chronic onset, then we think about a type of metabolic or hereditary disorders. More often, we have to consider the associated conditions or triggers. The course includes, there's a paroxysmal course, the static, progressive, or fluctuating. And associated features is the third principle. Includes birth and early development history, family history, medication, presence of systemic disease. In case of complex genetic disorders, it's important to be aware of pattern recognition that can help with diagnosis. I'm going to start with the case 1, the 7-year-old male with 1-year history of shaky hands. There was normal history of early life and early development. There's no history of systemic disease. The exam reveals low amplitude, postural and kinetic rhythmic oscillations in bilateral upper extremities. This is absent at rest. There's no pulling, twisting, or posturing on exam, and otherwise the exam is normal and there is no family history. We wanted to approach the differential diagnosis. The first step is to extract the pertinent points. Here, the phenomenology is suggestive of tremor. The tremor state is postural and kinetic, and it's absent at rest. The time course is chronic and persistent, and there is no association with systemic disease or abnormalities on exam or medications. A normal exam in this case can rule out entities such as ataxia, dystonia, Parkinsonism, neuropathy, or psychogenic disorder that each can be associated with tremor. Differential diagnosis. Tremor, by definition, is a rhythmic oscillatory movement caused by alternating or synchronous contraction of antagonist muscles. And it's important in case of tremor to pay attention to whether it happens at rest, action, and what's the distribution of it. Action tremor could be a tremor anti-gravity, which often is a postural tremor, or tremor during a task, which is called a kinetic tremor. A special type of kinetic tremor known as intention tremor or terminal tremor, known with exaggerated intensity of a tremor near target. It's often seen in cerebellar disease. And also, a tremor can be only seen with specific time. Also pay attention to the distribution of tremor, which is most often in upper extremities, but sometimes if you're aware of tremor in places, jaw, chin, tongue, or vocal cord, head, trunk, or legs, that can be helpful. For example, vocal cord and head tremor can often be seen in a common tremor disorder, essential tremor. Based on the phenomenology, we can start to build on the differential diagnosis. Rest tremor often is seen in Parkinsonian disorders. This is rare in children, but early onset genetic Parkinson's disease occasionally can be seen. And also juvenile Huntington disease, Westphal variant, can sometimes present with Parkinsonism in childhood. Parkinsonism secondary to metabolic disease is another cause for rest tremor. You also have to keep in mind dystonic tremor and Wilson disease. Postural and kinetic tremor can often be seen in essential tremor or enhanced physiological tremor, which is a higher frequency tremor, often with a low amplitude and often exaggerated by entities such as stress, anxiety, medications, and thyroid disease. The other forms of tremor that can be seen with posture or with kinetic tremor include dystonic tremor, cerebellar tremor. Midbrain tremor is a type of tremor usually associated with lesions in the brain and often present at rest, but more significantly with action. And task-specific tremor could be very specific to a certain task and otherwise absent. And tremor with Wilson disease, which often is a wing-beating proximal tremor, more significant with holding a posture or use of the hand, that can be seen at rest as well. So for this patient who has a childhood isolated and chronic action tremor, differential diagnosis includes essential tremor, enhanced physiological tremor. We're paying attention that this patient does not have any clear trigger for an enhanced physiological tremor. And some other entities to consider in a childhood isolated tremor include hydrocephalus, Klinefelter syndrome, hereditary neuropathies, and Wilson disease. This patient had a normal imaging, metabolic workup, thyroid test, and Wilson workup, and therefore the most likely diagnosis in this case would be a. So, although essential tremor is common, it's often thought that age of onset starts after age 9 or 10. So it's a little unusual to see the age of onset at an earlier age and may prompt some additional workup to make sure that no alternative etiology is missed. But it is known that the range of presentation of essential tremor can include earlier age of onset. Presence of a family history of voice and head tremor will increase the likelihood of the diagnosis, but it's not necessary. And treatment would include entities such as propranolol, primidone, topiramate, gabapentin in older children, often, more of a use of wrist weight or weighted utensils in younger children can be considered. Case 2. A 13-year-old female with 3 weeks of right-sided twitching. This patient had a sudden onset with gradual worsening over the past 3 weeks. There was a history of recent upper respiratory infection, and there are no other involuntary movements. Exam reveals random, non-stereotype, and flowing movements in right arm and hand. These are not suppressible, and there's otherwise normal exam. For a differential diagnosis, we pay attention to the 3 principles of phenomenology, temporal course, and associations. Phenomenology of these movements is suggestive of chorea. Chorea are random, involuntary, purpose-like, non-rhythmic, abrupt, and unsustained movements. These movements are not a stereotype, they're random, they're flowing. Chorea itself means dance-like in Latin. The distribution of these symptoms are unilateral because these are only present in the right upper extremity. The time course is subacute within a few weeks, but has been progressive. And associations of note include recent history of infection, but otherwise normal exam. Differential diagnosis of chorea in pediatric population include both acquired and genetic causes. There's this entity known as benign hereditary chorea. Most of this so far have been attributed to two genetic conditions, the mutations in ADCY5 gene and NKX2-1, which is also known as brain thyroid lung disease. Chorea in pediatric population could be post-infectious, most often Sydenham chorea associated with post-streptococcal infection. It can be seen in the setting of acute demyelinating encephalomyelitis, which is often has a lot more in addition to chorea happening at the same time. Vascular causes, infection causes, and autoimmune causes are all important acquired causes to consider in this population. Among autoimmune causes, lupus, antiphospholipid syndrome, celiac disease, and certain autoimmune encephalitis have been associated with chorea. Metabolic causes, especially hyperglycemia, can cause chorea, including unilateral chorea. Hepatic, renal, hyperthyroid dysfunction, and pregnancy, chorea gravidarum, can be other metabolic causes of chorea. Drugs and toxins can be causative of chorea. And also importantly, degenerative disorders. Now, most famous degenerative disorder associated with chorea is Huntington's disease, and this often happens in adult onset. As I mentioned, the younger onset Huntington often presents with Parkinsonism, but not with chorea. However, a number of other genetic conditions can present during childhood: neuroacanthocytosis, neurodegeneration with brain iron accumulations. Several of these entities are identified, and mitochondrial disorders all can present during childhood years. If ataxia is present, presence of chorea may be suggestive of certain entities, such as ataxia telangiectasia, ataxia with oculomotor ataxia type 1 or 2, DORPLA, or certain spinocerebellar ataxias. So in this patient, MRI of the brain was normal. There was no evidence of infectious or metabolic disease on the workup, and main differential, therefore, would be a post-infectious or autoimmune entity. There was no clear history of a streptococcal infection, although this always would be a consideration in this age group. In this patient, further workup revealed a positive antiphospholipid antibody. Among the autoimmune disorders that can cause chorea, lupus and antiphospholipid antibody in association with each other or occasionally separate from each other can be seen as a cause of chorea, and chorea can rarely be a presenting sign of such disorders. MRI in case of antiphospholipid antibody chorea sometimes could be normal, and other times could show evidence of a vascular injury. This condition often is treated with anticoagulation as well as immunotherapy, often in shape of a pulse steroid. Had a full recovery with initiation of anticoagulation and immunotherapy. In recent years, there has been a better understanding of a range of movement disorders associated with autoimmune disorders. This is mostly due to recent recognition of a number of antibodies targeting the neuronal cell surface antibodies, most prominent among them NMDA antibodies. And movement disorder can be a common accompaniment with these disorders, and in certain situations can be the presenting symptom, and therefore important that we consider these possibilities when we have a subacute presentation. NMDA antibody encephalitis has been associated with chorea, dystonia, and stereotypy type movements. This patient also can have a range of other symptoms, such as memory deficit, psychiatric symptoms, seizure, and dysautonomia, rarely with chorea or tremor. A neuroentity DPPX antibody has been associated also with myoclonus and tremor, but also ataxia and stiff person syndrome. 8-year-old male with paroxysmal movements. This patient has episodes of forced posturing of right arm, along with ataxic and spastic gait that last for 10 to 30 minutes. Episodes of intermittent and have been present for the past 2 years. They're usually triggered by exercise or fasting, and there is normal examination in between episodes. There is no EEG correlates during the episodes that rules out an epileptic etiology. There is a family history of a brother with seizure and intellectual disability, but no movement disorder history. So to build up the differential diagnosis, again, going back to phenomenology, temporal course, and associations. In this case, phenomenology is suggestive of dystonia in arm and ataxia and spasticity of gait. The distribution is unilateral in upper and bilateral in lower extremities. The time course is chronic, but importantly, paroxysmal. And associations include trigger with exercise or fasting, and a family history of seizure and intellectual disability. Now, when we have a paroxysmal course, that would be a very pertinent feature, and we usually use that to build our differential diagnosis. So the differential diagnosis of paroxysmal dyskinesia include primary entities that are genetic. This includes paroxysmal kinesiogenic dyskinesia, often triggered by sudden movement, sudden standing, also hunger or caffeine. Episodes are brief, from seconds to minutes, usually a combination of dystonia and chorea, autosomal dominant inheritance, and often good response to antiepileptics. Other big entities are paroxysmal non-kinesiogenic dyskinesias. These are not triggered by movement. They could be longer, last up to hours, and they don't respond very well to treatment. The third entities are paroxysmal exercise-induced dyskinesia. These are triggered by prolonged episodes of exercise, also by fasting or cold. Phenomenology include chorea or dystonia, but the phenotype can also include the spasticity and ataxia. Episodes characteristics last between 5 to 30 minutes. The fourth category, paroxysmal hypnogenic dyskinesia, which often happen during sleep, are now thought to be primarily epileptic and being some form of a nocturnal frontal lobe epilepsy, because are associated with large amplitude flailing movements. It's also important to consider the secondary causes of paroxysmal dyskinesia in pediatric population. This can include demyelinating disease. One of those examples are tonic spasms that can happen as a result of myelitis or multiple sclerosis or neuromyelitis optica. And these could look like dystonia, but often very painful, and in fact are more of a pyramidal signs that happen paroxysmally. Metabolic disorders, including endocrine disorders, mitochondrial disorders, especially early in the course, can be paroxysmal, and in this group also is biting time and responsive disease. The differential also include epilepsy, alternating hemiplegia of childhood, which has been associated with ATP1A3 gene, ADCY5 disease, which can present with benign chorea, but also include paroxysmal or lingual dyskinesia attacks that can characteristically happen during transition to sleep, episodic ataxic disorders, and neuromuscular channelopathies, such as myotonia or paramyotonia congenita, which sometimes can present with paroxysmal stiffness. In this patient, MRI of the brain was normal. CSF glucose was assessed and was low in the presence of a normal CSF, presence of a normal glucose in serum. And this led to checking for SOC2A1 gene mutation, which was present. The diagnosis is a paroxysmal exercise-induced dyskinesia. This is caused by glucose transporter 1 deficiency, which can be diagnosed by checking the CSF glucose and then confirming with the gene study. This is a treatable condition, so it's important to be diagnosed. It can be treated with ketogenic diet. It has a broader spectrum, and it could have variable presentations, including in members of the same family, as exemplified here. Movement disorders could be paroxysmal, but They can become persistent, for example, in a spastic ataxic gait years. There could be a history of early onset seizure or intellectual disability, but not in all the patients. So it's important to pay attention to that spectrum of presentation of the variables. Well, briefly talk about a couple of entities that should be considered when we think about paroxysmal dyskinesia. Biting thiamine responsive basal ganglia disease has been an entity that's been better characterized in recent years. Is often associated with SLC19A3 gene mutations. It could be paroxysmal, especially initially in the course of the disease, although it can become progressive and in some patients even fatal. It often presents with dystonia and encephalopathy, but can include ataxia, weakness, and seizure. Clinically, could be similar to Leigh syndrome, so mitochondrial disorder. These patients can have paroxysmal events triggered by infection or surgery or major stresses. There could be basal ganglia signal changes on the MRI, and these signal changes actually can improve with treatment. And this condition is reversible with thiamine and biotin supplementation if initiated on a timely manner. And this can be treated or at least stabilized by low protein diet and carnitine. Another entity that can present with paroxysmal disorders in childhood and important to be aware of it is ATP138 related neurological disease. This is an entity that has become more and more characterized in the past few years with expanding and variable spectrum. Alternating hemiplegia of childhood is part of a spectrum of this condition. These are paroxysmal events that, in addition to weakness, often involve dystonia. They can have a very characteristic monocular nystagmus involving only one eye on a paroxysmal basis, and also sometimes seizures, and can be triggered by infection or stress. Up to 50% can develop persistent deficits. The same genetic condition can include a presentation in form of rapid onset Parkinsonism dystonia. These are patients who develop Parkinsonism and dystonia, a lot of them during childhood, with acute onset within days, but there is often no infection. They get encephalitis identified as a cause. They become stabilized without progression, but are refractory to levodopa and other treatments. And a third entity also related to this gene is CAPUS, cerebellar ataxia, pes cavus, optic atrophy, and sensorineural hearing loss, which can present in an older population. So, case 4, 9-year-old female with twisting neck and jerking arm. This patient had normal birth and early development history, onset of arm jerking at age 6, onset of neck turning to left at age 8, and family history of jerky movements in father. Exam revealed persistent and repetitive slow pulling and turning of neck to left and sudden rapid jerky movement on arm and shoulder. This jerky movement can get worse during writing and was not suppressible. So here the phenomenology suggests dystonia in neck and myoclonus in arm and shoulder. Dystonia is a sustained, repetitive, and pattern movement can causing twisting and posturing. And distribution here was focal, affecting the neck. Myoclonus is sudden, brief, rapid, shock-like involuntary movements, and in this case, they are present at rest, so they are called spontaneous myoclonus, but also can be induced by action, such as writing. The time course is chronic, but it's progressive course, and there's a family history in father. Differential diagnosis of dystonia is broad, and we pay attention to both distribution, which sometimes help to narrow down the differential diagnosis, as well as the etiology. When we think about dystonia, we want to know if it's focal. Often focal dystonia start in adults, and it's unusual in children to have focal onset dystonia, and usually we have to think about secondary or lesion-based causes. Examples of dystonia being focal include around the eyes, spasm, in the neck, torticollis, task-specific, like writer's cramp with arms, or laryngeal dystonia. It could be segmental, involving a couple of regions next to each other, such as craniobrachial dystonia involving face and arm, which can be seen in a type of genetic dystonia called DIT6. It could be multifocal, or in one side of a body, called hemidystonia. In hemidystonia, we often again should think about secondary causes or lesions, such as a stroke or AVM or demyelinating lesion as a possible cause. I often should image them. And it could be generalized, which by definition means a dystonia that involves trunk and lower extremity, and these often start during childhood. One of the more common ones is DIT1 dystonia associated with torsion mutations. Also, this includes the category of dopa-responsive dystonia. And dystonia can also be seen as a primary disorder along with other movements. So true examples are dystonia Parkinsonism and myoclonus dystonia. The second axis when we think about dystonia is the etiology. So the range of secondary causes for dystonia, again, is broad. Infectious, vascular, autoimmune, toxic, or demyelinating processes should be considered. But also is a broad range of neurodegenerative disorders, including lysosomal storage disease, mitochondrial disorders, amino acid and organic acidurias, Wilson disease, CSF neurotransmitter disease, and degenerative ataxia. So again, have to pay attention to the company it keeps. If dystonia is present with other movement disorders, that can sometimes be helpful. For example, if dystonia is present along with myoclonus, it could be dopa-responsive dystonia, but also the myoclonus dystonia as a distinct entity associated with alpha-sarcoglycan mutation. And the same way associated with other primary movement disorders can sometimes narrow down the range of differential class. Now, this 9-year-old patient, a Wilson workup was pursued and was negative, although the age of onset of Wilson usually is in teenage years. But when we see onset of movement disorders in children, we usually look for that, especially if they have dystonia. MRI of the brain was normal, which can help to rule out a number of secondary and lesional causes. And given a family history, chronic course, dystonia, and myoclonus together, the concern was raised for myoclonus dystonia and was confirmed by finding a mutation in alpha-sarcoglycan gene. This is the most common cause of myoclonus dystonia, which can also be caused by a couple of less common genetic etiologies. Often it is autosomal dominant process, and there could be variable degree of myoclonus or dystonia in different family members. An important feature of this form of primary genetic dystonia is that it's more common in upper body and can be treated with a number of entities such as anticholinergics, tiracetam or sodium oxybate, although often medications have some limited benefit. It's also responsive to surgical therapy. A couple of entities of note when we think about dystonia in childhood include dopa-responsive dystonia. So every childhood dystonia should be challenged by levodopa because there are some that will respond very well to the levodopa. This is also differential for spastic dystonic cerebral palsy. And some of these patients that have been misdiagnosed during childhood may be diagnosed during adulthood after they're challenged by levodopa. A key feature of the most common form of dopa-responsive dystonia is diurnal variation. The symptoms are better in the morning after sleep and worse in the evening. They also often start in the leg around age 5 to 10. There's some variability in terms of that. Is an autosomal dominant inheritance, but due to incomplete penetrance, there may not be a clear family history, but only family history may be some adult family members who have focal dystonia or late onset Parkinsonism. The GCH mutation associated with Sagava disease is the most common one, but there are a number of neurotransmitter disorders that can also present as dopa-responsive dystonia, such as tyrosine hydroxylase and other entities. The other entity of note that has been better characterized in the past few years are the manganese transport disorders. So these are often associated with SLC3810 gene mutation. A couple of other rare mutations have also been identified. This presents often with childhood onset dystonia, but there could also be Parkinsonism, dysarthria, hypotonia, and abnormal type of dystonic gait known as cock-walk gait. The labs can show high serum manganese, and there may be polycythemia or liver disease present. The characteristic MRI findings include hyperintensities in bilateral basal ganglia on T1 sequence. This is something we see in patients who, for example, have manganese toxicity or in liver failure, which have accumulation of manganese, and is very characteristic. This is treatable by manganese chelation as well as iron supplementation, but again, important to be identified early to prevent irreversible neurological injury. I'm going to also mention another mode of treatment available for patients with pediatric dystonia, deep brain stimulation. That's becoming applied more frequently to manage these patients. Deep brain stimulation consists of implantation of chronic leads in the deep part of the brain, in the basal ganglia, and they're connected to wire that can be programmed. So who would be a good candidate for deep brain stimulation treatment in pediatric population? The primary application currently is for generalized primary dystonias, such as DIT1, DIT6, and other generalized primary dystonias. It's the main indication in children, and there is an evidence of benefit that earlier treatment can be more beneficial to these patients rather than waiting until years later. It also has been increasingly used as a rescue option in selective severe dystonias that are caused by secondary or complex disorders, such as status dystonicus, which is a severe dystonia that cannot be treated with any other measure in select patients. And in this situation, results vary based on etiology. It's an effective therapy for severe primary and secondary tremor disorders. Often it's been done in older patients, but obviously a child with very severe tremors is something that can be considered. It's also rarely used for juvenile Parkinsonism, but it's an option for treatment of adult Parkinsonism. There has been an accumulation of information about which type of patients with different types of dystonia may benefit most. There is a good amount of evidence in patients with primary dystonia that they can have between 60 to 80% improvement possibility. DIT1 has been most often studied. Dystonia now is being more increasingly considered. So I'm going to conclude here to emphasize again that it's important to have a stepwise approach to pediatric movement disorders. Phenomenology, temporal pattern, and associations are the three principles of our approach, and we should always have a focus on treatable and urgent conditions. Thanks for your attention.
We would like to appreciate and acknowledge Professor Homayoun for his great lecture. And now we are honored to have the presentation of Professor Suvasini Sharma with the topic of pediatric autoimmune encephalitis. Please, let me to remind you some hints. One of them is that this webinar is broadcasting live on our YouTube channel. And please make sure that you have muted your microphone. And if you have any question, you can use the chat section below your screen. And if you want to receive a certificate of attendance in this Congress, make sure to register on our website. And the address of the website is mentioned in the chat section. And reserve a seat on your desired panel. And for our Iranian audience, if you want to receive CME credit. Don't forget to participate in the panel quiz in maximum of 2 days in semiquiz.ir. It would be appreciated to have the Pediatric Autoimmune encephalitis by Professor Sharma. Thank you.
Thank you very much. I really want to thank the organizing committee for giving me this opportunity. It's really a big challenge to organize an international conference in these difficult pandemic times, which I think you've done a very good job. And after discussing status epilepticus and movement disorders and epilepsy, we move on to another topic, which in fact includes all of these things. This is one condition which will have seizures, movement disorders, and many, many other problems, as you will see. Now, autoimmune encephalitis is best conceptualized as an umbrella term which includes several disease types. And the subgroups are classified based on whether the presenting autoantibody is targeting the cell surface proteins, intracellular synaptic proteins, intracellular antigens, or is linked to a known paraneoplastic process. The diagnosis of autoimmune encephalitis no longer relies on the response to immunotherapy, nor does it rely on any particular antibody status. So it is actually, in a way, a clinical diagnosis and exclusion of, say, infections and other common differentials that you should be aware of. And confirmatory is the antibody testing, but this takes time and it may not be available in low resource settings. So a clinical recognition to start treatment very promptly is very important. So what is really very important to understand is these are treatable disorders. And as is very nicely quoted, immune therapy is better than none. Early treatment is better than late. And if a patient fails the first line therapy, second line therapy should be very promptly and early considered. However, we don't have many trials or any randomized trials, in fact, to help us guide treatment. These are mostly based on retrospective cohort studies and expert opinions. And what is again important to understand is despite the major advances in the field, a large proportion of children with suspected autoimmune encephalitis are seronegative. And these patients may have unidentified autoantibodies or more likely other immune mechanisms wherein antibodies don't play much of a role. So there are a lot of barriers in pattern recognition. First of all, there is a potential for delay in diagnosis. We always think of other common causes like encephalitis, ADEM, metabolic disorders. So this kind of comes late in the differentials, and these antibody testing are not very easily available. So what is very suggestive of autoimmune encephalitis are acute to a subacute onset of symptoms with very rapid decline. So autoimmune instability in the form of breathing difficulties, hypotension is again a very suggestive clue. These patients can quickly progress to delirium and catatonia. They can have what we call polysymptomatic presentation. That presentation in multiple domains. They can be seizures, they can be movement disorders, they can be autonomic disturbances, psychiatric symptoms, catatonia. So when you have a mixture of symptoms like this, one must think of autoimmune encephalitis. So the subtypes commonly seen in children, what we most commonly see is anti-NMDA receptor encephalitis. And this is what I'm going to talk about in detail, because the other subtypes are really very rare in children, and these tests are again not very easily available. And these phenotypes are much more common in adults and not common in children. There are the subtypes of anti-GABA receptor encephalitis, anti-glycine receptor, basal ganglia, anti-GAD, and the limbic encephalitis, which is seen with a host of antibodies like VKGC, Caspar-2, GABA-B, AMPA-R, and DPPX, but these are mainly seen in adults and really very, very rare in children. So coming to the commonest form of autoimmune encephalitis in children, which is anti-NMDA receptor encephalitis, and this is the leading cause of seropositive autoimmune encephalitis in children. Initially, this was described in adult women with ovarian teratomas, but later it has been described in men, women, and children with and without teratomas, and in all age groups, and it has also been described in infants. Approximately 40% of cases present until the age of 18 years, and the characteristic diagnostic feature is the presence of CSF IgG antibodies against the blue N1 subunit of the NMDA receptor. Clinical features: most patients will develop first prodromal symptoms such as headache or fever, And this is followed by rapid change of behavior in the form of anxiety, agitation, insomnia, aggression, visual or auditory hallucinations, paranoia, psychosis, or catatonia. So then there comes the stage of movement disorders with very, very predominantly orofacial dyskinesia. So a lot of lip and perioral movements. Again, this is very, very suggestive of NMDA receptor encephalitis. If you see a patient who's evolving into stages, the first stage being some lethargy, going on to mutism, psychiatric symptoms, then movement disorders. And these movement disorders can first develop into chorea, athetosis, valismus, stereotype movements, rigidity, or epistotonus. But as symptoms progress, the children develop decreased consciousness, stupor, coma. There can be periods of agitation alternating with catatonia. Autonomic dysregulation is a very frequently seen problem in this condition, which can manifest as fluctuation of blood pressure, hypothermia, siluria, tachycardia, breathing difficulties, and less frequently even arrhythmias like bradycardia, cardiac pauses, or ictal asystole. Seizures and status epilepticus may occur at any stage of the disease. In young children, the behavioral changes can be difficult to detect because they often present with temper tantrums, hyperactivity, or irritability, as opposed to frank psychosis. The first symptom to be recognized is often non-psychiatric. They can present with seizures, status epilepticus, dystonia. Mutism or verbal reduction is a very, very common feature, very frequently seen. And they may require sedation because of intense anxiety and insomnia. So this is a child. You can see the movements. So a lot of agitations, a lot of continuous movements. This is what is very frequently a characteristic feature of these patients. A lot of orofacial dyskinesias and continuous movements. But what is very heartening is after treatment, this child is almost back to normal. So very, very important to recognize early and treat early. Another patient. You can again see this rapid stereotypic movements which this patient is having, movement disorders continuously. This is another child, again with rapid continuous choreothetoid and stereotypic movements. This is another child. This child presented with a reminder presentation. She had ataxia and speech difficulties, and she was speaking much lesser than she used to speak. Now, CSF was strongly positive for anti-NMDA receptor antibodies. And after treatment, you can see that she is back to normal. She's talking normally. Her coordination is back to normal. So the three phenotypes are classic psychiatric predominant, which is a good outcome, and catatonia predominant, which has poor outcome. So basically, like I said, it evolves into various stages, starting with the prodrome. Then there is agitation, psychosis, catatonia, memory deficit, speech reduction and abnormal movements, going on to coma, hypoventilation, and dysautonomia, and improvement also occurs in the sequential stage. Sometimes atypical forms can be seen, which include predominant or isolated psychiatric symptoms, seizures, or dystonia, but these are very uncommon. And the most common scenario is the patient is that once they have a predominant symptom to start with, and later they develop symptoms or milder manifestations of other elements of the syndrome. So in children, young children, they can have an autistic regression kind of a presentation which presenting with gait disorders, like in the patient child I showed you earlier, has also been described. And it can even present as it can mimic a neural malignant syndrome. So certain differences are there when you compare the presentation in children as compared to adults. Children much more frequently have seizures, movement disorders, speech disturbances, and sleep pattern disturbance. And at the illness peak, again, children very commonly have seizures, movement disorders, and behavioral changes. Autonomic cardiac is much more common in adults. In children, it is hypertension and hypothermia. And in adults, you will very frequently find it's paraneoplastic. So ovarian teratoma or other tumors are very common. But in children, it is commonly suspected post-infectious. Teratomas are not very common, especially not in prepubertal children. So how do we investigate these patients? Of course, in any child who is presenting with an encephalitic presentation, you get an MRI done. That is normal in 70% of the patients. 1/3 of them may have non-specific cortical or subcortical abnormalities, sometimes involving the medial temporal regions. Very rarely, there can be extensive demyelinating abnormalities. Some cases of overlap with the NMO spectrum or MOG spectrum have been described also with the NMDA receptor encephalitis. EEGs will usually be obtained because these children have seizures, but they are mostly non-specific, slow and disorganized. But one particular peculiar pattern has been described in about 1/3 of the patients, the pattern of extreme delta brush. Now, delta brushes are normally seen in preterm, very preterm baby EEGs. Normal preterm baby EEGs are 24-weeker, 26-weeker, 28. They will have, so when you see a delta brush in an older child who's comatose, these are the delta brushes. Like on delta waves, you have this zigzag pattern. This is what is known as a delta brush. This extreme delta brush pattern is quite suggestive of anti-NMDA receptor encephalitis. CSF, of course, will be done in these patients. So CSF is initially abnormal. They may be abnormal, and you may have moderate lymphocytic pleocytosis, mild or normally increased CSF protein. But what is very, very important to see is to look for the anti-NMDA receptor antibodies. So it's very rare to have positive serum, but absent CSF. So CSF is much, much more important and specific. Problems with serum testing is that if the diagnosis is delayed or the patients have received a treatment already, like plasma exchange with IVIG, you may not find the antibodies in the serum, but only in the CSF. Patients with protracted clinical course or persistent symptoms may be seronegative, but they may persistently have CSF titers until the symptoms improve. Okay? Findings are consistent with a disease in which immune response is initially triggered by a tumor or other unknown causes and then reactivated and expanded in the CNS. Tumor workup is indicated in all the patients, but depending on the age, the yield, like in a small child less than 6 years weight, very unlikely to find a tumor. So in prepubertal children, unlikely to have tumors, but in older patients, especially the reproductive age group, definitely very, very high chances of finding a tumor. So the bottom line is, the younger the patient, the less likely that a tumor will be detected. All patients should be examined for the presence of an underlying tumor, mainly an ovarian teratoma or a testicular germ cell tumor. The first concern in female patients should be to screen for an ovarian teratoma. Most useful screening tests include MRI, CT scan, and pelvic ultrasound. Periodic whole body screening usually is not necessary unless the patient's severity is with very severe disease, relapses. Then, of course, you have to look for it very, very carefully. Certain diagnostic criteria have been described so that you can quickly diagnose the patient and start treatment without waiting for the antibody testing. And again, antibody testing may not be available, quite expensive, and it may not be available in a lot of low resource settings. But because it's such a treatable disorder and the treatment is immunotherapy, steroids, which are easily available everywhere, one must be able to diagnose it clinically even without the availability of antibody testing. So rapid onset of at least 4 of the 6 major group symptoms, which include abnormal psychiatric behavior, seizures, movement disorders, mutism or speech dysfunction, decreased level of consciousness, and autonomic disturbance or central hypoventilation. And at least one of the following laboratory results, which shows abnormal EEG or a CSF, and reasonable exclusion of other disorders. For example, a viral encephalitis. That is the main thing you need to exclude, an infectious disease. Okay? So if all this is met, then you can make a diagnosis of probable anti-NMDA receptor encephalitis, which becomes a definitive diagnosis when you have the positive antibody. And of course, definite will be there even if one of any of these features are present, with reasonable exclusion of other disorders. So these criteria have been found to be very highly sensitive and specific. In one study in 29 children with NMDA receptor encephalitis and 74 comparison group, what was found that the percentage of patients increased with time because some of these criteria may not be present at the beginning. So you have to wait 1 or 2 weeks to fulfill the criteria. So the best is, if you're suspecting it, rule out infection and start the therapy and get the testing done, wait for the results and see. Now, another entity to be aware of is post-viral autoimmune encephalitis. Anti-NMDA receptor antibodies causing relapsing post-herpes simplex encephalitis has been seen in 20% of patients with HSV encephalitis. So what happens in these patients is that they start the typical herpes encephalitis, they're given acyclovir, they improve, but after improvement, they start showing prolonged relapsing symptoms such as encephalopathy, movement disorders, seizures. So in such a scenario, one must think of anti-NMDA receptor encephalitis and look for these antibodies. If they are positive, Then along with acyclovir, these patients also need to be given immunotherapy. The patients will improve. Coming to the other types, like I said, these are very, very rare. So I'll describe them very briefly. Limbic encephalitis is non-viral inflammation of the limbic system, which means the mediotemporal lobe, amygdala, and cingulate gyrus. So this is the temporal lobe, mainly deals with emotions and memory. So patients will present with amnesia, seizures, psychiatric disturbances, emotional problems, and this is really very, very rare in children. So typically caused by onconeural antigens and GABA-B and VKGCs. So in one small study, what was found is that these patients have this changes in the limbic region and present with encephalopathy, memory changes, and emotional disturbances. GABA-A receptor again are very rare in children, but one clue here is the MRI shows these demyelinating kind of multifocal hyperintensities. DR2, anti-basal ganglia encephalitis, presents with, like the name itself suggests, bilateral basal ganglia symmetrical hyperintensities and clinical features of dystonia Parkinsonism. GAD receptor again is rare in children, but in adults is associated with stiff person syndrome, cerebral ataxia, autoimmune epilepsies, and limbic encephalitis. So one thing which is more common than these other types of autoimmune encephalitis is one, and pediatricians need to recognize, is Hashimoto encephalopathy, which is now also known as steroid responsive encephalopathy associated with thyroiditis. This is characterized by altered mental status, seizures, movement disorders, and cognitive dysfunction. It's more common in females, especially adolescent age groups. This disorder is generally associated with thyroid diseases, and the most common present feature is the presence of anti-TPO antibodies. But just getting a thyroid testing may not get you the diagnosis because patients are usually euthyroid at presentation. So you must get a TPO testing done, and if that is elevated, therapeutic options include steroid treatment. Prognosis ranges from complete recovery to a relapsing course, and sometimes, rarely, especially the treatment is delayed, they may develop long-term cognitive sequelae. So Hashimoto encephalopathy should definitely enter in the differential diagnosis of every patient with rapidly progressive dementia. In children, it should be suspected when they present with acute or subacute new onset seizures and changes in the level of consciousness. Triad of encephalopathy, EEG slowing, and increased protein content in CSF should prompt testing for antithyroid antibodies in the blood and CSF, regardless of the thyroid function. So to summarize, when should you suspect autoimmune encephalitis? Whenever there's a polysymptomatic presentation, that is many symptoms, encephalopathy, seizures, movement disorders, mutism, sleep disturbances, psychiatric and autonomic disturbances, acute to a subacute onset, may follow a viral prodrome. MRI and CSF are normal or not suggestive of an infective process, and deterioration after a period of improvement in a child with viral encephalitis. So a huge list of workup is suggested in these patients, which includes serum tests, CSF tests, imaging, ancillary studies. So this is, of course, a very huge list and may not be practical in all settings. So practically speaking, at least MRI, CSF cytology, biochemistry, and viral PCR studies, EEG, antibodies, and if it's a low resource setting, at least CSF anti-NMDA receptor, because getting both of done, sometimes the cost is double. So blood alone may be negative, may even sometimes be false positive. So at least get a CSF testing done, and thyroid status and TPO. And what is most important is do not wait for the results to start immunotherapy, as early treatment has better outcomes. Basic principles of treatment are that patients treated with immunotherapy fare far better than those who are not given immunotherapy. Tumor screen is important and supportive care is important. So we have to start the first line immunotherapy, starting pending the results. So what we give is pulse methylprednisolone, 30 milligram per kilogram per day for 5 days. And we also give concomitantly IVIG, but plasma exchange can also be given instead of IVIG. But in children, of course, logistically, IVIG becomes much easier to give. Some people only give steroids if the patient is not very severe, especially. After this, you must wait for at least 2 weeks for the response. And child has responded very well. This is followed by oral steroids, followed by a slow taper. For patients who do not respond well to this, partial responders and non-responders, second line immunotherapy needs to be given, which is usually rituximab. Rituximab is a chimeric monoclonal antibody against CD20, results in B cell depletion. So you must look for the B cells and monitor them 3 to 6 monthly, especially if you want to give a retreatment, redosing of rituximab. So look for the B cell. When the B cell repopulation occurs, then the second dose is given, which is usually after 3 to 6 months. So another cheaper alternative is cyclophosphamide, and it has broad cellular immune suppression effects. So rarely you may need third line agents, which are bortezomib and tocilizumab, and sometimes rarely intrathecal steroids and methotrexate have also been tried. And not just immunotherapy, but supportive and symptomatic treatment is also important in these patients. This includes sedating agents for sleep, relieve agitation and emotional imbalance. And for this purpose, benzodiazepines, clonidine, and chlorohydrate are commonly used. One must avoid neuroleptics. Anti-epileptics, of course, are needed for seizures, and we have to manage the respiratory depression and dysautonomia. So this is a algorithm. In any child with suspected autoimmune encephalitis, we screen for infections, screen for tumors, and start empirical first-line therapy, which is usually IVIG, methylprednisolone along with IVIG or plasma exchange. If there is no response, we go to the second-line therapies, which is usually rituximab or cyclophosphamide. And in refractory, of course, keep periodically screening for tumors in these patients who are relapsing or not improving. And then the third-line therapy like bortezomib and tocilizumab. So to summarize, we must consider autoimmune encephalitis in the differential diagnosis of a child who presents with acute or subacute onset of altered sensorium, with or without fever and a febrile prodrome. So I'll again say this: when we get a mixture of features, either sequentially or together, encephalopathy, psychiatric disturbance, movement disorders, especially the orofacial dyskinesias, seizures, autonomic disturbances, consider this. So a polysymptomatic presentation, but symptoms evolve over time and one symptom may predominate at one particular time. In a young children, consider this when there's a developmental or autistic regression and a gait disturbance. A significant proportion of them may be seronegative. Diagnostic criteria may help but take time to get fulfilled. Early clinical recognition and starting immunotherapy is the key to improve the outcomes. Thank you very much for a patient hearing, and I'll be happy to take any questions if there are any.
Thank you, Professor Sharma, for your spectacular presentation. Any questions will be available on the chat section, and at the end of the today's session, we will ask you. Thank you. And we are going to have the presentation of the Professor Sreeni Tekki-Rao with the subject of status epilepticus. Please take note that this webinar is broadcasting live on our YouTube channel. And due to the number of participants, please make sure that you have muted your microphone. And if you have any question, you can use the chat section of the Zoom application. And if you want to receive a certificate of attendance in this Congress, make sure to register on our website. We have linked our website in the chat section. And don't forget to follow our social media pages and our YouTube channel. Professor Tekki-Rao, we will be honored to have your presentation. Thank you.
Hello, good evening, dear esteemed scientific colleagues in Iran and worldwide. My name is Dr. Tekki-Rao. I'm not sure whether I'm being shared or not. I couldn't hear myself.
Professor, we have your presentation, but your slides are not shown on the screen.
Thank you. My name is Dr. Tekki-Rao. I'm pediatric consultant with a special interest in pediatric epilepsy and pediatric neurology. I'm working just north of London in England. Today I'm going to talk on similar topic as Dr. Gabriella Di Rosa has got a different tint to it. I'm basically looking at the concept of changing our therapeutic protocols. So outline of my talk is background and incidences of the convulsive status epilepticus, and the definitions are almost covered by Dr. Di Rosa. Morbidity and mortality, and a brief context of that in terms of how this is going to change our thoughts in future. There is new evidence that is existing since 2018 with a lot of addition of a new therapeutic randomized control trials have taken place. So where do we go with this new evidence adding to our scientific knowledge? So this is the most common, most serious and life-threatening neurological emergency. concurring with Dr. D. Rosa, I just say that the mechanisms of how convulsive status epilepticus continue is that the failure of termination of the seizure or mechanisms that initiate that lead to abnormally prolonged seizures. Literature of convulsive status epilepticus has been there since 600 to 700 BC, but advances started happening only since 1970s with the advent of benzodiazepines as a major breakthrough. Until then, we've been using amyl nitrate, amobarbital, bromide salts, diazepam, peraldehyde, phenobarbital, and pentobarbital. You can look at some of those physical treatments, which they included lumbar puncture, CSF drainage, keeping the children in dark rooms with rest, etc. However, I think there was no good protocols or approach. Mostly it had been individualized practice in each hospital worldwide. So the definitions, traditionally it has been that a seizure that lasts for 30 minutes or more without regaining consciousness between the seizures has been a traditional definition. Again, as Gestalt in 1973 stated, that a condition characterized by epileptic seizures that are sufficiently prolonged or repeated at sufficiently brief intervals so as to produce an unvarying and enduring epileptic condition. But I think ILA has stepped in for more than a century now, and I think that they have been changing the definitions, of which in 2015, as Trinka et al. Put in their paper, that the operational definitions are slightly different from a definition taking it as 30 minutes, in which tonic-clonic status, if it is lasting for more than 5 minutes, it's a time period 1 where we need to start acting. Whereas time period 2, where if it is beyond 30 minutes, there is a neurological injury likely to happen. Whereas for focal status with loss of awareness, it is decided as 10 minutes, whereas it could be up to 60 minutes where neurological injury can set in. Unfortunately, absent status has got no clear definition or clear understanding. Mostly these operational definitions are also quite arbitrary. An impending or premonitory convulsive status epilepticus is that with a seizure more than 5 minutes, whereas an established one over 5 minutes that has not responded to first-line anti-epileptic drugs. A definition of refractory comes in place when we have given a second class of anti-epileptic drug, which is phenytoin or phenobarbital, and recently levetiracetam and valproate. Super-refractory is that continues for more than 24 hours, even after giving onset of anesthesia, or recurs after that. So incidence has been worldwide between 15 to 25 per 100,000 children a year. In a town where I'm practicing, a population of 300,000, I would expect 100,000 children. So in our emergency department, I might be expecting 1 to 2, at least 2 every month as a status epilepticus. Highest incidence is seen in children under 3 years, but the mortality in general is about 3 to 4% in all children with status epilepticus. Whereas if it becomes refractory, up to 32% mortality can go up to, whereas in super refractory, even up to 60%. However, this figure is derived from adult population. Tonic-clonic status is quite frequent in children and those with learning difficulties and those with cerebral pathology. Unfortunately, even though mortality may not be the outcome, but children could end up with cognitive decline and chronic epilepsy. So why should we treat aggressively? Again, this pathophysiology has been covered by Dr. D. Rosa. Thanks very much for her. But just in a summary, generalized status could lead to loss of pyramidal neurons, loss of cerebellar Purkinje cells, and also nerve cell loss to the cortical laminae 2 and 3. A very good work in the 1970s by Meldrum and Brielli, who have experimented on baboons, and they found that the status over 90 minutes, precisely about 83 minutes, led to the ischemic changes in hippocampus, neocortex, and cerebellum. And of course, acute hippocampal injury can happen even in the absence of ischemia or hypoxia, because they have experimented on baboons which were ventilated. So hypoxia was eliminated from their equation. So this is a picture of a normal hippocampus having had a prolonged status over 90 minutes. You could see loss of the layers H1 and H3 to 5, whereas H2 seem to be remaining unaffected. There are lots of etiological factors for status epilepticus, of which the most common is prolonged febrile status. And the second common is acute symptomatic epilepsies. Acute symptomatic seizures are because of so many other, within this parenthesis, you could see acute bacterial meningitis, viral CNS inflammations, acute metabolic conditions, hypoxia, head injury, and cerebrovascular accidents together. Remote is those more than a seizure has happened more than 4 weeks ago, and it could be because of any hypoxic injury or acute symptomatic seizures. Rest of the causes seem to be following, such as acute on remote, idiopathic, cryptogenic, and unclassified. So worldwide, there are some protocols. However, why do we need protocols for this management of convulsive status epilepticus? It is because that the factors that determine the mortality and morbidity, of which even the etiology and age seem to be on the top of the common factors, duration, which is modifiable. We cannot perhaps change etiology and age of the presentation, but the duration can be modifiable. So quicker we act, quicker we could achieve better results. A seizure that lasts more than 5 minutes is likely to last for at least 30 minutes. So as we have seen, a seizure lasting more than 30 minutes is likely to cause more cerebral injury. The autoregulation also will be lost if the seizure goes beyond 30 minutes, and therefore cerebral edema sets in and ischemic injury to the brain sets in. This is why the mortality goes very high in those admitted to the intensive care and also super-refractory epilepsies. So there are so many protocols existing worldwide. In UK and Europe, they follow advanced pediatric life support guidelines and also National Institute of Healthcare and Excellence guidelines. Both are almost similar. Whereas in America, they have slightly different protocols based on American Epilepsy Society. Australia follows APLS, Australian version guidelines, and Canada has got Pediatric Society, Canadian Pediatric Society. Similarly, Hong Kong has got Hong Kong Epilepsy Society. Rest of the world, some individual regions have got their individual protocols in their country. However, most of them depend on textbooks based on American guidelines. A typical APLS or NICE guideline protocol is like this. In the first step, we need to be stabilizing the airway, checking airway breathing circulation is stable, followed by within 5 minutes, if the child is still continuing to have seizures, this is where we start interacting or intervening. Midazolam is quite popular in the United Kingdom and in Europe, which is given buccally. If child is seen by a paramedic or an ambulance crew, they give rectal diazepam. However, if the child is in hospital, lorazepam intravenous if an intravenous access has been established. 10 minutes following the first administration of benzodiazepine, the second benzodiazepine dose is most popular and most commonly followed. By this time, if a line is set up, lorazepam can be given. If not, again, similar like rectal diazepam or buccal midazolam could be given. at 25 minutes, which is actually the second line of management, where we use phenytoin, and if the child is on phenytoin already, phenobarbital is given. We do not, generally, APLS does not advocate other anti-epileptic drugs until recently, which I'm going to discuss how this may change in future. However, after finishing of phenytoin infusion, which takes nearly 20 minutes, then third line, which is rapid sequence induction with anesthetic agents, should be set in. American Epilepsy Society guidelines are slightly different. These are based on the new guidelines in 2018, where they have introduced valproate and levetiracetam in their second line, whereas fosphenytoin was introduced about 10 years ago in American guidelines. But fosphenytoin apparently is expensive and is not available in the European market. Third phase almost is similar. So having had established guidelines, why do we need to change? As I was mentioning, these 4 important randomized control trials have been emerging as a new evidence, which I'm going to discuss individually. So PICU admissions seem to be still high, even though these guidelines have been followed. There was an Ireland latest study suggests that about 50% of those following APLS guidelines seem to be admitted to intensive care. And from Australian study, 22% seem to end up in intensive cares. Similarly, phenytoin has got a risk of fatal arrhythmias and Stevens-Johnson syndrome, and also that it is a very long infusion, at least 20 minutes, and the end time success rate could be at least 25 to 30 minutes after the infusion. Therefore, I think we need to think about alternatives for this one. And also there were some studies by Tully et al. In 2015. They have studied that the protocols, there have been a deviation. For example, giving 3 benzodiazepines or giving excessive doses without following these protocols might be the failure of the causes. So coming to the first line drugs, is there any new evidence in the usual protocol of using benzodiazepines? Apparently not. There was 2004 Cochrane review was there, followed by 2018, a latest review by Dr. McTaggart et al., which shows that in this tabulated form, I've shown some of those studies which have been revised and reviewed. 18 randomized control trials have been looked at, of which 2,199 participants have been pooled in to look at the results. There were a range of treatments, range of doses, and routes were looked at. Even though rectal diazepam was so popular before, buccal midazolam started coming in since 2004, 2005 in United Kingdom, which has become more popular. They have compared rectal diazepam versus buccal midazolam in 4 of those randomized control trials. There are about 690 children participated in these pooled studies. There is a slight favoring of buccal midazolam over rectal diazepam. Of note, even in nowadays, America seem to use rectal diazepam as their favorite first line community setting treatment in their settings. Also in UK, we still use rectal diazepam if a paramedic or an ambulance crew arrives. Whereas if we are giving any training to parents, we prescribe buccal midazolam so that they can administer themselves. The quality of these studies seem to be still low. Other studies are buccal midazolam versus intranasal lorazepam. There is only one study. Even though this is a high quality study, 141 children, there is no favoring of either buccal midazolam or lorazepam. There was another study about intramuscular midazolam versus intravenous diazepam. Again, there is no favor on either of these drugs. Similarly, IV lorazepam versus diazepam was compared in 3 good trials. Even though quality is low, there is again no favoring of either IV lorazepam or diazepam. Looking at adverse effects, respiratory depression seemed to be between 0 to 18%. And just outside this Cochrane review, but not into the conclusions, is that the lorazepam is slightly favored over diazepam with a risk ratio of 0.72. So one of the recent studies, which I cannot escape mentioning, is from Doha in Qatar. They've compared intramuscular versus buccal midazolam in pediatric seizures. It's a randomized double-blinded trial conducted very efficiently with 150 children aged range between 4.5 months and 14 years. They treated acute seizures with either intramuscular or buccal midazolam and compared them. And in this table, it shows that intramuscular had a seizure cessation in 61% of the individual compared to buccal midazolam. And the seizure duration following administration was about 15.9 minutes compared to slightly prolonged buccal midazolam. So in the seizure cessation group, there is a significant difference between buccal midazolam and intramuscular midazolam, giving a little favor. However, there is some thoughts about the administration of intramuscular. It is not possible quite easily by parents and teachers in a community setting. And also that pain could last for up to 24 hours after giving intramuscular midazolam. But obviously in the hospital, perhaps it could be one that could be considered, and also with the paramedics. Coming to the second line drugs, if the convulsive status epilepticus lasts for more than 10 minutes following 2 doses of benzodiazepines, traditionally phenytoin has been used since 1950s, and fast phenytoin in USA since 2010. Phenobarbital may remain an alternative, but between 2015 and 2018, very good simultaneous random control trials have taken place in UK, Australia, New Zealand, and USA. So let's just go through them briefly. First one of them is ECLIPSE study. It's an emergency treatment with the levetiracetam and phenytoin in convulsive status epilepticus in children. This took place in about 30 centers. They have compared levetiracetam 40 milligrams per kilo in 5 minutes of infusion against phenytoin 20 milligrams per kilogram over 20 minutes infusion. 286 children have participated after exclusions between 6 months and 18 years. Seizure cessation has happened successfully in about 70% of individuals in levetiracetam group versus 64% in phenytoin group. Median time for cessation from the start of infusion was 17.5 minutes in levetiracetam versus 24.5 minutes in phenytoin. There is no significant difference between either seizure cessation or median time of cessation. So the conclusion is that there is no difference, but levetiracetam is favored due to the ease of administration and a safety profile. So the second study is concept study, which is a convulsive status epilepticus in pediatric trial. It's in New Zealand and Australia. 233 children have participated in this between 3 months and 16 years. It's again a very good, study with a good number of children participated. 152 in levetiracetam group compared to 134 in phenytoin group. Similar to UK, they have also used 40 milligrams per kilo of levetiracetam infusion, which is given over 5 minutes, compared to 20 milligrams per kilo of phenytoin. Seizure cessation was seen, I just jumped it. 119 children in this concept study, which is 40 milligrams per kg and 20 milligrams of phenytoin. Their endpoint was that seizure cessation should be 5 minutes after completion of infusion. Their success rate was about 50% in levetiracetam versus 60% in phenytoin. Again, not statistically significant. And median time to cessation from the start of infusion was 17 minutes in levetiracetam and 22 minutes in phenytoin, comparable to UK study. The conclusion is that levetiracetam is not superior to phenytoin, but there is further extension they have done. They looked at some secondary outcomes in which there was a simultaneous sequential administration of other trial drug. For example, if that was a levetiracetam infusion, they have given phenytoin if there is no cessation of seizure. In phenytoin group, they have given levetiracetam. So ultimately, they have taken 2 steps here in the line 2 management: levetiracetam followed by phenytoin, or phenytoin followed by levetiracetam. So their estimate is that it takes approximately further 10 minutes in administration of these 2 drugs. And if we look at their outcomes, in a phenytoin group, whereas the primary outcome was only 60% success rate, 37% of them had levetiracetam as a second trial drug in the second line. They have achieved 78% success rate by the end of 2 hours, compared to the levetiracetam group, where there was only 50% success rate. They have given phenytoin further in another 40% of individuals, and they have achieved 72% success. So again, these 2 groups are comparably, there is no statistical difference in them. Rapid sequence induction was required in about 22% in all of these children in total. If a third study, which is very important, that took place in the same time period in United States of America, they've compared levetiracetam with fosphenytoin and valproate, and they have also used this trial for comparing the outcomes in children, adults, and elderly. Elderly group is a little bit small. 225 children and 237 adults have participated in this, and their outcome, primary outcome is there absence of clinical seizure at 60 minutes with no additional anti-epileptic drug. The difference between UK and UK and Australia studies and USA study is that levetiracetam was used at 60 milligrams per kilo in the infusion, whereas fosphenytoin and valproate are similar. Valproate was not used in other 2 trials, but valproate was used at 40 milligrams per kilo. So results were again dissimilar. Levetiracetam group 52% success rate, fosphenytoin 49% success rate, and valproate is 52% success rate. There are no age group differences between children, adults, or elderly. And adverse reactions were rare. Significantly more children with the phenytoin have required intubation. This is an observation that is slightly interesting to note. So their conclusion was that any of the 3 can be the first choice or second choice after benzodiazepines. Third line management, looking at the recent research, there is not much of research on this. So people have different choices. Mostly they prefer thiopentone, and some of the anesthetists may prefer propofol, but there are some side effects for thiopentone and pentobarbital, that the hypotension is a common side effect, so you may have to just flush them with a lot of fluids. Infusion of midazolam seemed to be the third preferred choice. Tachyphylaxis is one of the common side effects, where 24 to 48 hours after infusion, you may have to increase the dose of midazolam. Ketamine seemed to be taking some popular route in some of the units. So now, having had this new evidence added to our line of thinking, we need to see what kind of changes we can make. It looks like first line of drugs, benzodiazepines remains choice, and I don't think we're going to make much of difference. However, route of administration, we may think differently. Now, in the second line of drugs, where even though many of the hospitals have been using, without scientific evidence, valproate and levetiracetam, now we have got very good grounds. However, the effectiveness of these 2 drugs still remain including phenytoin, is between 50 and 70%. Valproate, could that be added in children? There are some limitations to the valproate in children. In children less than 2 years, there is a risk of hepatotoxicity due to unknown Pol-G mutations causing mitochondrial disease with severe hepatotoxicity and liver failure. And over 12 years, Medicines and Health Products Regulatory Agency has given a very good full stop to sodium valproate in the reproductive age group. Therefore, we cannot use, even though we can use an emergency treatment, for example, levetiracetam, it was used, we can continue as a prophylactic medication following the emergency admission, whereas valproate cannot be used in girls over 12 years. Therefore, that's one of the limitations. Currently, this is the protocol that we have been using traditionally. First aid followed by airway breathing, circulation, and glucose checking, followed by 5 minutes later, buccal midazolam. Of course, in some settings differently is rectal diazepam. Then 10 minutes later, IV lorazepam. 10 minutes following the second dose of benzodiazepine, phenytoin or phenobarbital, and 20 minutes following this, it is IV thiopentone. So overall, it is 35 minutes before we think of rapid sequence induction. Now, how it may look in future. Buccal midazolam may remain the choice. However, some people may start thinking about intramuscular midazolam or intranasal lorazepam. Still, they seem to be equally effective. Followed by the child is in the hospital, a IV lorazepam or IM midazolam could be added. Second line drugs, even though phenytoin has been there, now we could add either levetiracetam or valproate as a possibilities of choice within your units, or national protocols might have to change. What I'm very not sure is, can we add in the second line, like in concept trial, a second line, second drug after infusion of phenytoin and levetiracetam? We could use, in case of phenytoin, we could use levetiracetam. If it is levetiracetam used, we can use phenytoin. But we should be aware of the time that takes extra, and which may still may be detrimental to the child if they develop cerebral edema with prolongation of control. Whatever the changes that may take place, I think still we need to be very sure that the first line response need to be very robust and brisk. More quicker we act with the first 5 minutes, more better will be the outcome. If there is a delay in first line, there could be a knock-on effect on the second line drug effectivity, but this is not proven yet. And what about the timing between doses of the medication? Traditionally, we are using first 5 minutes as very much standardized and accepted internationally, that after 5 minutes, we start intervening with the drugs because most of the seizures stop within 4 minutes. But what about further steps of 10 minutes, 10 minutes, and 20 minutes? Is it appropriate, or should we change it? That's also another one. And lastly, as we looked at the phenytoin and levetiracetam and valproate, the best response that we could see between 50 and 70%, do we need another novel second line drug? That we have to think about. So I'm just coming to a conclusion. I presume we're going to take questions after in the final session. Summarizing, convulsive status epilepticus remains a significant emergency, neurological emergency worldwide. Standard protocols are existing, and there is slight variation in different regions, but now there is a new evidence emerging for the second line treatment of status epilepticus, particularly levetiracetam and valproate. I think we have to think back to rechange our protocols and adapt this new evidence into our protocols. Thank you very much for listening and your attention.
Thank you, Dr. Tekki-Rao, for his great, spectacular presentation. And we are going to, right after this webinar, we are going to have the session about the pediatric intensive care unit hot topics. The suggest you to participate in this and do not miss it. Cordially, we wish you healthy and happy time. Take care. Thank you.
Sharma